Hi, good afternoon, everybody. Welcome to the next session, session 3. Where are we going next in breast cancer? My name is Dr. Ryan Tan. I'm from the medical oncologist from the National Cancer Centre, Singapore.
And I am Dr. Norfadlina, Dr. Nina Abdul Sattar from Pantai Hospital, Kuala Lumpur.
So we're very excited. We have a very broad range of talks, short talks, spanning new therapies to health econs, to diet and exercise, all interesting topics that I'm sure your patients ask you about. And to help us kind of disentangle this, I think we'll introduce the speakers one by one. So maybe I'll go ahead to introduce the first speaker. So first speaking to us will be Dr. Tira Tan. I think you've met her already from a previous session. So Tira's a great breast medical oncologist who also serves as the Deputy Director of the Clinical Trials Unit at the National Cancer Singapore. And among our colleagues, we know that Tira's always the one looking for possible new therapies for some of the patients who have really seen many of the others. So I think she'd be a very good person to talk to us about novel new treatments in breast cancer. So Tira, over to you.
Thank you, Ryan, for the introduction, and to Rebecca and the organizing team, thank you for inviting me and the opportunity to speak today. I'll just wait for the slides to come up. There you go. And before I begin, these are my disclosures. So over the next 10 minutes, I'll give a rapid tour of where novel therapies in breast cancer are headed. Beyond the new drugs, I would like to discuss radioligand therapy and cellular therapies, which have represented a step change as they use targeted radiation and engineered immune cells with mechanisms of actions that are completely distinct from what we are comfortable with as a current standard of care, and they can only be delivered in specialist tertiary centers with nuclear medicine, with cellular therapy and trials capability. So let me start with the ER-positive, HER2-negative disease, where we've already lived through one revolution with CDK4/6 inhibitors. The key question now is what comes after progression of CDK4/6 plus endocrine therapy. So here we are seeing a clear role for targeting the PAM pathway, PIK3-AKT-mTOR axis, as well as other resistance pathway on top of endocrine therapy, particularly in tumors with PIK3CA, AKT, or PTEN alterations. This means that clinically in those patients after CDK4/6 inhibitors, we are no longer jumping straight into chemotherapy, and instead we're layering on pathway inhibitors on top of endocrine therapy. Second, the next generation cell cycle and epigenetic agents with a particular focus of CDK2. CDK2 seems to be one of the escape routes after CDK4/6 inhibitors, so now we have selective CDK2 and 4 inhibitors in development, aiming to resensitize tumors that have somehow learned to bypass the CDK4/6 blockade. Alongside this, epigenetic modulators are also being explored to reverse endocrine resistance by reprogramming ER signaling rather than just blocking it. Third, endocrine therapy innovations themselves. Oral SERDs are already changing our practice, especially in ESR1 mutated disease, with interesting trial design aiming to intervene early at the sign of molecular progression. SERDs are also being joined by PROTACs, such as vepdegestrant in the VERITAC study. PROTACs are bifunctional small molecules that physically bring the estrogen receptor and E3 ubiquitin ligase together, which then triggers an ubiquitination and proteasomic degradation of both the wild type as well as mutant ER. And finally, we're seeing that ADCs are moving earlier in sequencing, where ADCs were historically reserved for later lines. We are now seeing them tested immediately after endocrine therapy, as we've seen in the DESTINY-Breast06 approach. Turning to HER2-positive disease, here I'll focus strictly on HER2-amplified and not on HER2-low disease. The first major story is the expansion of trastuzumab deruxtecan into earlier lines of treatment. In the metastatic HER2-positive disease, we've moved TDM1. TDXD has replaced TDM1 as a preferred second line, and you've seen data now that is moved up front in the first line setting. But what's truly novel is pushing it into the curative setting, where we have seen data from DB05, DB11, where TDXD is being applied in a neoadjuvant setting. The second key development is maturation of CNS-active HER2 TKIs. The tucatinib-based regimens have really changed how we think about managing brain metastases in HER2-positive disease, demonstrating not only intracranial response, but also survival benefit. So there is a shift from using whole brain irradiation as a default to considering targeting with CNS penetrant therapy as a part of the systemic plan, even in the setting of active brain metastases. And finally, we're seeing a next wave of HER2-targeted agents with novel mechanisms. And this includes the biparatopic antibodies like zanidatamab, which simultaneously binds two different epitopes on HER2, which then promotes tight receptor clustering, enhanced internalization, and therefore more potent HER2 downregulation than single epitope antibodies. Beyond antibodies, new antibody-drug conjugates are being developed now with alternative payloads such as MMAF, instead of, which are microtubulin inhibitors, using more stable linkers. Layered on top of this is immunotherapy in HER2-positive disease. Checkpoint inhibitors alone have had modest results, but when you combine it with HER2-directed antibodies, which then serves as immune activators, we're seeing more promising results. And one interesting strategy here is to pair HER2-targeted agents with CD47 inhibitors like evorpacept. I'm sorry, the names of these drugs are impossible to pronounce, that removes this don't eat me signal on the tumor cells, right? So this biology is now being tested on the ASPEN-09 breast phase 2 study, which we are expecting to open in my institution imminently. Triple-negative breast cancer, I think, is where the story is most rapidly evolving, and importantly, I think it's a story that's not quite finished yet. The first major theme is ADCs are moving up front. ADCs with and without immunotherapy in PD-1 or PD-L1 positive or PD-L1 negative TNBC. We are seeing them being placed in the first-line setting, with guidelines now adjusting recommendations in favor of this approach. The second theme is TROP2-directed antibody-drug conjugates are now being developed across the entire disease spectrum, where Tropion-Breast06 study is part of a larger program that is evaluating Dato-DXd as frontline option in advanced TNBC. In parallel, the TROFUSE study, which evaluates SAC-TMT, also another TROP2 ADC, now is shifting or utilizing this compound in neoadjuvant and the adjuvant setting for management of triple-negative breast cancer. And the third theme is next-generation immunotherapy for TNBC, and here we are seeing bispecific antibodies, novel checkpoint combinations, and IO regimens tailored for PD-L1 negative cancers. The Rosetta study is one example, which pairs a PD-L1 VEGF bispecific with chemotherapy in an attempt to create an immunological hot environment even when the baseline PD-L1 expression is low. So now let me briefly pivot to radioligand therapy, or RLT. Radioligand therapy is a form of targeted radiation therapy comprising three key components: a ligand, a linker, and a radioisotope. The ligand recognizes and binds a specific tumor-associated target, and this could be targets such as GRPR, which is gastrin-releasing protein, or a stromal marker like FAP, which is fibroblast activation protein. The linker connects the ligand to the radioactive payload and is engineered to be stable in the circulation and yet allow effective delivery to the tumor. The radioisotope is commonly an alpha or a beta emitter, such as lutetium-177, that then delivers highly localized radiation to the cancer cells and its microenvironment. And this gives rise to a concept of a theranostic. We can first use a diagnostic radio tracer with the same or similar ligand tagged to a gamma-emitting isotope for imaging to confirm target expression and dosimetry. If uptake is then adequate, we then administer the therapeutic version with a beta or alpha-emitting radionuclide, essentially using the imaging scan to be our biomarker. Currently approved radioligand therapies are mainly outside of breast cancer. For example, PSMA-targeted lutetium therapy in prostate cancer and somatostatin-targeted agents in neuroendocrine tumors. However, this research space is rapidly expanding into new targets that may be highly relevant for breast cancer. Two that are attracting a lot of attention are FAP and GRPR, the gastrin-releasing peptide receptor. And by targeting stromal receptor level features, these radioligands may then allow us to treat both the tumor cells as well as their supporting microenvironment. And you can see here the studies that are available in Singapore, where we're very fortunate to be part of this global ongoing efforts with agents that target, so the NeoBCAP1 targets GRPR, and the second study with DFC413 targets FAP. For our patients, these trials offer access to a genuinely new mechanism of action, especially for those who have exhausted conventional therapies, conventional endocrine therapies, HER2-directed therapies, or chemotherapy. From a systems perspective, they are also building our local expertise in theranostic, dosimetry, as well as multidisciplinary collaboration between us, medical oncologists, the nuclear medicine physician, and our radiation oncologists. Now let's move on to cellular therapy. At a high level, cellular therapy means we're using living immune cells as medicines, engineered or expanded outside the body, then reinfused back to attack the cancer. There are three main flavors that are relevant to our solid tumors: the CAR-T, T-cell receptors, and tumor-infiltrating lymphocytes, or TIL therapy. CAR-T cells express synthetic receptors that recognize surface antigens independently of HLA. TCR therapies enhances or introduce T-cell receptors specific for intracellular tumor antigens presented by a particular HLA molecules, so they are more restricted but can target a broader antigen repertoire. TIL therapy expands a patient's own tumor-active lymphocytes harvested from their tumor environment itself without genetic modification. So just to give you an idea about what I have to do sometimes when we have these patients on TIL therapy, this is our TIL therapy pathway. The journey starts with a surgical resection of a tumor deposit. The tumor is then sent to a specialized lab where TILs are isolated and they are expanded ex vivo, often with high-dose IL-2 support, to generate a large population of tumor-active lymphocyte. The patient then receives lymphodepletion, followed by infusion of the expanded TIL product, and then a course of systemic IL-2 to support T-cell engraftment. So for those of you who are as old as I am, and you can remember treating metastatic RCC and melanoma with IL-2, that's basically how it's like now. So I think in breast cancer, this is still early days compared to melanoma or lung cancer, but these platforms are now entering breast-specific trials, particularly for those that may be heavily pretreated or molecularly selected. So these are some of the rising numbers of solid cancer cellular therapy trials. I'm sorry that it's come out a bit awkward. But all of these innovations, ADCs, radioligands, cellular therapies, ultimately reach our patients through clinical trials. And at NCC, we're actively building our portfolio, as I've tried to illustrate, portfolio of early and late phase trials in this area, together with our early therapeutics team, And so we do have a clinical fellowship that focuses specifically on trial methodology as well as novel agents. So for any of our colleagues here in the audience, or if you have any junior faculty who might be interested in joining us on this effort, please ask them to email this, or you can contact me anytime. So to close off, I think the novel therapy landscape in breast cancer is no longer defined by one big breakthrough, but I think by multiple overlapping waves, and I've just tried to highlight some of those that are currently in development. Thank you very much for your attention.
Thank you very much, Tira. I think you've shown us that there's many potential, no shortage of potential new drugs for our patients in the near future. And following hot on the heels of that, we're going to talk about the price of that progress, or get our next speaker, Dr. Eric Finkelstein, who's a health economist by training. He's a professor of health services research and also executive director of the Lien Center for Palliative Care. Many publications over the years, including, as I understand, one that was cited by the US Supreme Court upholding Obamacare. So very interested to hear his views on the economic and psychological impact of advanced cancer treatment.
Yeah, so thanks so much. Thanks for having me. So yeah, I'm a health economist, so I must confess the only part of Tira's talk I understood was when she said some of the words were hard to pronounce, which is true. So let me switch gears a little bit. So in this presentation, I'm going to talk a little bit about the way patients make decisions and what we think might influence those decisions. So you can see from my talk, hope bias and health-seeking behavior. So that's a bit of a heads up where we're headed. Now, you guys are not the right audience for this, but typically when I presenting to a general audience, I'll ask the question, how long do you think people diagnosed with an advanced stage 4 metastatic, like an advanced cancer, are likely to live? What do you think a typical guess is? Pretty short, 6 months, 1 year, not very long. Now, people like us who will go, or at least like me, sort of uneducated people who don't know much about cancer, will unfortunately go on and at times will get cancer. Now, the second question is when you ask those people and you say, okay, how long do people diagnosed with an advanced cancer think they're likely to live? And you can think about people just diagnosed. What do they say? Well, it turns out they'll say much longer things like, I can beat it, I can be cured, I'm going to live a really long time. And so the question is, why the disconnect between general adults, knowledgeable people, and people who are suddenly diagnosed with this advanced life-limiting illness? So what's the disconnect, right? Well, basically, in one word, it's hope. So something switches in our brains when we're diagnosed with this illness or when our family member is, and suddenly it's us, right? Now, it begs the question, well, what actually is hope, right? Well, it turns out it's not so easy to define. So for you poets out there, Emily Dickinson has, describes hope as the thing with feathers, it's birds chirping, it's all of these wonderful things, it's the morning dew, blah, blah, blah. Sounds great. But it turns out, for you philosophers, Friedrich Nietzsche defines hope as the worst of all evils because it prolongs the torments of man. And those of you who treat advanced illness patients, I'm sure you can recognize both of these with your patients. And the reality is, for some individuals, hope is amazing, and we certainly would not want to dispel hope. But for others, hope can get individuals to make all sorts of decisions that ultimately might get them to spend all of their savings and actually have a far worse end-of-life experience. Now, if you look at the literature or if you search on ChatGPT, you'll see something like the below. Hope is a transient state of mind that results from a negative circumstance, basically on an outcome that you would really like to see happen, right? So certainly an advanced illness or advanced cancer is consistent with where you might expect to see somebody have lots of hope, and why you might see people change behavior very quickly than, say, when you're asking a general audience, well, how long do you think people live with cancer versus, okay, you were just diagnosed with cancer, how long do you think you'll live? But here's where it gets interesting, okay? So What I want to talk about now is basically what happens when you're diagnosed with this this life-changing event and hope is kicking in. Well, it turns out what happens is bias kicks in as well, and your patients are not making decisions based on the information that you're telling them. They're making decisions based on filtering that information through their biased brains and recoding lots of that information. Now here, this slide is actually really important. This is based on our COMPASS cancer cohort in Singapore of 263 advanced cancer patients. But in fact, we see this on lots of different patient populations. And basically, the way to interpret this figure is basically the x-axis is just the age at which people died in our cohort. And the y-axis was upon enrollment, the age at which they thought they would die. And basically, we wouldn't expect people to be able to predict their own demise, but if they could, all of the dots would be on the red line. Now, if people were just randomly guessing, half the dots would be above the line and half the dots would be below the line. But in fact, what you can see is that almost every single patient is overly optimistic relative to their own survival. So they all think the treatments that you're offering them are going to work better than they actually do. And they're making decisions based on these probabilities. Now, let me show you a little bit more detail about what's happening to drive these dots. So the conceptual model is basically this. There are characteristics, time-varying and time-invariant characteristics of individuals that will influence hope. And those characteristics that influence hope then will go on and influence bias in many different directions, or many different types of bias, I should say. Those biases will influence their prognostic beliefs, which will in turn influence their health-seeking behavior, as well as the amount of money they're going to spend trying to extend their life. We've published quite a few papers on this, and we have quite a few that we're still working on, but let me just give you some of the data from a second study called SHAPE, which was, again, with our colleagues at the National Cancer Center looking at patients with advanced cancers, as you can see on the screen. Now, what we did with our SHAPE cohort was basically we gave them something called the Hearth Hope Index, which is one of several measures out there that can measure how hopeful patients are. And then we went on to track these individuals over time and to look at some of the biases and then eventually health outcomes, costs, and health-seeking behavior. Now, it turns out in Singapore, our patients are very hopeful. Whether or not this would be true elsewhere, I'm not sure, but certainly you would expect that when people have these advanced illnesses, hope kicks in. So it's not surprising that these patients are quite hopeful. Now, what may be surprising is what are the implications of that? Well, it turns out that if you feel good mentally, when we surveyed these patients, they report 7.6 higher score in the HHI. If they don't have pain the day we surveyed them, they had 3 points higher in the Hearth Hope Index. If they hardly ever feel lonely, they were 6.5 points higher. And in fact, younger patients were also a little bit higher, as were more religious patients. So these factors influence the levels of hope in the sample. Now, let me show you how that hope relates to factors related to their beliefs about curability. Well, it turns out each 1 point increase in the Hearth Hope Index was associated with a 6% odds in believing their illness is curable, a 4-month increase in expected survival, a 6% increase in the odds of believing that their survival will be better than the average patient, 5% increase in the odds of believing that the primary intent of their treatment is curative, so a bit of cognitive dissonance, and 11% increase in believing that they're very well informed. Presumably, they're getting the same information as every other patient, to the point that if you compare a more hopeful to a less hopeful patient, they think they're going to live 4 years longer. Now, it turns out, at least based on our data, they don't. So there's no evidence that hope actually extends survival, and that's important for 2 reasons. One is, if this hope is leading to more health-seeking behavior, which it does, you would expect that those treatments should extend their life, which they don't seem to. Now, if you also believe that there are some physiological reasons to think that hope might actually improve survival in the absence of any extended treatment, there's some evidence relating to positive outlook and inflammation, and that inflammation, if you can control inflammation, you could get better survival outcomes. We don't see it here either. But let me tell you what we do see. Basically, in our particular sample and shape, we didn't see hope leading to greater health expenditures or healthcare utilization, but when we talk to the clinicians, they say anecdotally that they have some pretty good systems in place in the cancer center to prevent people from overtreatment, but that people certainly will leave the public hospital and go private or go to alternative providers in a way to get initial treatment. Now, I will say in a subsequent study where we looked at a different sample, we actually found that people with greater curative optimism, more likely to believe that they could be cured from treatment, actually spend about $8,000 more in the very last months of life, in the last 3 months of life. So we are seeing greater levels of optimism, curative optimism bias leading to higher costs. Now, you can ask yourself, what are the implications of these research? But basically, I have 20 seconds left. In my last 20 seconds, I just want to make the point that from an economist's perspective, we like to see when people are getting additional treatments when they believe that the perceived benefits are greater than the perceived costs based on the information that's presented to them. But the reality is patients are recoding that information, and because they're overestimating the benefits of treatment, whether it's publicly subsidized or not, we're seeing greater utilization and greater expenditures. And so I think there's a reasonable discussion that we should have. How do we help these patients make better choices such that we're not prone to the type of hope or bias-induced overtreatment that we think is not good value for money? So I'll stop there, and hopefully we can have time for questions. Thanks.
Thank you so much for that. I think this afternoon we will really be diving into how we can help our patients in clinic, really pragmatic tools that we can review. And I think that was a very important statistics for us oncologists to have a look, because I think this is new data for us. I mean, we're saturated with Kaplan-Meier curves already this morning. So next we'll have Tam Wai Leong from Singapore, who's the Deputy Executive Director of the Genome Institute of Singapore. And he oversees the precision medicine effort to understand the genetic and genomic underpinnings of health and disease. And really, he'll be speaking to us about, will my diet influence my cancer?
So first, many thanks to Rebecca, Suchin, Sahina for this kind invitation to speak here. So Penang is a fantastic venue. And then Rebecca says that I should talk about diet and cancer. I said, yes, I want to talk about that, but I need to do some homework first. And so last night, I did some serious homework, going to the famous hawker places. But this is really important to what I'm going to tell you about, right? So the oyster omelette, ongwak, char kway teow, laksa you see here has two things in common: high fat, high carbohydrates, which translate into high sugar, right? Which you will hear more about later on. So I'm not a clinical, not a doctor by training, but many of my clinical partners have told me that when the cancer patients go and see the doctor, they have two levels of question, right? The first is relating to their tumors, their cancer, how long they have left, what treatment options they have. The second is relating to, what diet should they take and what exercise should they do and what other extrinsic factors can help in controlling the cancer or improving the treatment outcome. So another thing that I want to say is that I thought that this was a 20-minute talk, so I prepared a 20-minute talk slide, so please bear with me. So first, the disclaimer, I'm not a real doctor, okay? I don't see patients, so I'm not going to give medical advice. I'm this sort of doctor who is a scientist trying to understand how the cancer cells work in terms of their metabolic underpinnings. So on the image on the left here, you can see clearly that this is a PET CT scan. And this patient is metastatic, and you can see all the lesions present, right? And this technology only works because of one thing. Tumors are addicted to glucose, so they require a lot of glucose. They uptake glucose, and that's why we can image these tumors in the patient. But all cells require glucose to function. No cells can live without glucose, right? But in the normal tissue, glucose is utilized in two ways, dependent on whether oxygen is present or absent. In the presence of oxygen, they undergo what we call oxidative phosphorylation, which is the efficient way of utilizing glucose generating ATP. When oxygen is absent, they use another process called glycolysis, which is really an inefficient way of generating ATP. But the tumor cells doesn't care whether oxygen is present or absent. They will activate glycolysis anyway, and this is called the Warburg effect, discovered almost a century ago by Otto Warburg. And next is that, cancer as a genetic disease is dogma. We know that when the normal cells proliferate over age and gain mutations over time, some of these cells will gain the correct combination of mutations. So once they hit this correct combination of mutations, they undergo what is called transformation events, and the cells go from normal to become cancerous. And the bottom oncoprint you can see here, this is our work in liver cancer, which shows you that different tumors have different combinations of mutation, often associated with gain in oncogene and also the loss of tumor suppressor happening at the same time. But in the next 15 minutes or so, I want to convince you that also persuade you to view cancer as a metabolic disease. And here on the right, you can see this is a cell, and there are various nutrients going into the cells. And these nutrients activate different cellular processes in the cell, such as the gene expression program, changing in biosynthetic pathways, and changing in signaling events. So all these nutrients are important for cancer cells to reshape their ability to adapt, grow, and also to invade and metastasize or resist therapy. So there are several paradigms we think about in terms of cancer metabolism, which is the field that I work on. So the last 2 decades have focused a lot on the cell intrinsic behavior. As cells switch between treatment naive to treatment resistance, as you have heard, go from a primary tumor to become metastatic, or switch from epithelial to mesenchymal, switch from stem cells to become differentiated, they undergo what we call cell plasticity to adapt to these different processes. And through this adaptation, not only do they change in their expression program, but they also change in their metabolic needs in terms of how they handle nutrients and what they use these nutrients for. And many of these previous work in the past 2 decades have gone into targeting different metabolic pathways in these different cell states to target metastatic cells or to target tumor refractory cells. But the last 5 to 10 years have taught us something different, which is the fact that if you look at the middle part of the diagram, you can see here that there is a lot of crosstalk happening between cells. And we have known for a very long time that cells exchange signaling factors. But we now know that they not only exchange signaling factors, but they also exchange metabolic components such as different metabolites that's between the tumor cells and also tumor microenvironmental cells that could include those of the fibroblasts, the macrophages, the immune cells, and also the endothelial cells as well. So this sort of metabolic crosstalk is important for cross-feeding between tumor cells and also the TME component as well. So the tumor microenvironmental cells form only one source by which these nutrients can be provided to the cancer cells. There's another source, which is the diet that we eat. Many of these diet that we eat becomes digested, metabolized, and they go into the tumor microenvironment, and they also feed the cancer cells. And this is when we think that nutritional intervention could be useful in terms of how we modulate the diet, in terms of affecting the systemic nutrient composition in the humans, or in this case, the mouse, and see how that would influence cancer progression or treatment responses. And glucose is the major source of nutrients and energy for all cells. The right side of the diagram is to show you that metabolites do not only involved in a lot of these biosynthetic processes, but they're also involved in many of these control of gene expression programs. Just to give you a few examples, glucose goes into forming the TCA cycle, then forming citric acid, and then also forming the acetyl-CoA that's important for acetylation of this histone that drives the control of the expression program. Another example is methionine that we take from our diet, especially red meat, egg. Also, methionine is used to form this metabolite called SAM or S-adenosine-methionine, which is important for methylation of histone, of DNA, of protein. So in essential, a lot of these metabolites are connected to a lot of the gene expression programs in the cell and controlling how the cells behave afterwards. So metabolites are not just building blocks for macronutrients, but they're also involved in gene expression program. So we heard a lot about how sugar is bad for health overall, and there is a lot of epidemiological evidence to suggest that high glucose actually increases cancer risk. But this is a real study by a group that showed that high fructose corn syrup can actually enhance the intestinal growth of tumors in mice. So here in the center top diagram, you can see that given high fructose corn syrup, the mouse do not necessarily gain weight, but actually it has an influence on how the tumors progresses in these mice in the intestinal tissue. You can see here on the left in the control one, they form small adenomas, But when given high fructose corn syrup, these adenomas are a lot bigger. They are not only a lot bigger, but when they are allowed to progress over time, they form invasive carcinoma as seen from the bottom right part of the micrographs shown here. And what is the mechanistic connection? This high fructose corn syrup gets converted to glucose through a process called glucose neogenesis. And in doing so, this glucose goes through various metabolic cascades that then causes the formation of various fatty acids such as palmitate that then drives the proliferation of these cancer cells because a lot of these fatty acids are used to form cell membranes. So here is evidence, at least in animal models, to show that sugars can accelerate tumor growth in animal models. So we move from sugar to high-fat diet that we are all familiar with. Some years ago, our lab has shown that fatty acid in the cell has at least 2 fates. So in a more less invasive cancer, such as adenoma that's non-invasive, the fatty acid typically is used to form fatty acid or lipid deposits in the cells for which the function is still unclear. However, when the cells invade and become metastasized, where they have this metastatic competency, they now actually use fatty acid for a different function, which is to go into the mitochondria through this process called beta oxidation to generate energy and to produce this acetyl-CoA that I mentioned to activate this invasive program called the epithelial to mesenchymal cell transition. And when we did this work, we did not really look at how diet would actually influence this, but having said that, we underpin the fact that fatty acid is important for metastasis to happen. And then 2 years later, this group at KU Leuven in Belgium, Sarah Berry-Fan, went on to show that actually, if you give the mouse a high-fat diet for breast cancer models, you can actually promote metastasis. And how they do this is this. The high-fat diet causes the increase in palmitate levels in the lung interstitial fluid and also that in the liver in the bottom left diagram shown over there. And in doing so, they provide the environment with very rich palmitate levels that the cancer cells can uptake when they metastasize to the tumor microenvironment and cause them to adapt and stay permanently and be able to form micro to metastatic macro metastasis shown there as seen through the increase in metastatic nodules upon giving high-fat diet. What about amino acids? So this is an interesting study coming out from the Cambridge Greg Hannon's lab, where they showed that, where they accidentally found that actually asparagine have the ability to also promote breast cancer metastasis. In these bar diagrams in the middle panel shown here, you can see that when they give the mouse 4% asparagine, it increases the tumor growth and also the metastatic competency of the cells. And they proved that asparagine is important for metastasis by giving the mouse asparaginase, which actually breaks down asparagine, and this prevents the metastatic competency of these cells. And why this is interesting is because when they published this finding, there was a lot of hoo-ha in UK, especially amongst farmers of asparagus, where asparagine is found. And they really actually has an impact on the sales of asparagus during that point in time. So you can see that how many of these understanding of diet and cancer has actually social economic roles as well. So next is ketogenic diet. This is familiar to many of us because from the general media, it has always been purported that ketogenic diet is good for health. And this is important because in the healthy individual, ketogenic diet is indeed helpful for maintaining health because it reduces glucose, reduces inflammation overall. But does it have a different effect in cancer patients? This is an important question to answer. So basically, in a normal diet, you will have high composition of carbohydrates as your base of the pyramid, and then you have your protein, and then you have a little bit of fat. But ketogenic diet means that now you have more fat, more protein, and very little sugars. And the reason is that now it forces the liver to produce ketones instead of producing glucose. So it's burning fat and reducing the overall glucose level. So this study was in fact trying to address the role of PI3 kinase inhibitor in various forms of cancer. So as you have mentioned previously from Tira, PI3 kinase inhibitor is used to treat PIK3CA mutant tumors, but they do not work very well. Why is it that they do not work very well? And here comes the TAR3 connection. So what the study found was that when mouse models are given PI3 kinase inhibitor for these mutant xenograft tumors, you can see that there is this increase or sharp peak in this blood glucose level that is in circulation shown there. And not only does the blood glucose go up, there is also the increase in insulin to compensate for high glucose levels through that. And this has effect because this will actually prevent the efficacy of the PI3 kinase inhibitor, because insulin will produce a feedback loop to activate insulin growth factor receptor and thereby continuing to drive downstream process of AKT activation. So thereby the effect of this PI3 kinase inhibitor is being propagated in these tumors or in these cancer models. So how can we exploit this information that PI3 kinase inhibitors will actually increase glucose levels? So the logical thinking here, which they were smart enough to find out, was that what happens if you reduce blood glucose levels? And they could give the mouse ketogenic diets in this case. And you can see here very dramatically in the last curve is that when they give the mouse ketogenic diet in the presence of this PI3 kinase inhibitor, they block the tumor growth completely. Because in doing so, what happens is that they prevent the use of fructose or glucose in the animal model, in the cancer cells, and also prevent the elevation of this insulin growth factor signaling pathways, and thereby dampen AKT signaling and kill off the tumor cells. And finally, coming to the last part of this presentation is also the fact that, in the tumor microenvironment, the levels of nutrient present within the tumor is very different depending on whether vasculature is present or not. And this vasculature, as I mentioned, brings nutrients to the different cells. And whether a cancer cell is near or far to vasculature has implications on how they receive glucose, how they metabolize various nutrients. And many of these resistant or tumor stem-like cells that we see in the tumors tends to be away from vasculature, suggesting to us that they may have ways to adapt to the use of other nutrients other than glucose, which is rapidly consumed by these rapidly proliferating tumor cells. And this is a study we published quite recently in November that talks about how we can harness the effect of ketogenic diets to enhance certain forms of cancer therapy. Basically, what we found in lung cancer is that tumor-initiating cells actually have the ability to resist glucose deprivation. That means you remove glucose, the bulk tumor cells will die, but the cancer stem cells can continue to survive. And the reason that they can do this, we found, was that they activate these ketogenic pathways in terms of their ability to utilize and harness ketones as a way to overcome the depletion of glucose that's being consumed by these bulk rapidly proliferating tumor cells. And this is work with the National Cancer Center, which I am now a part of, and also of Duke NUS Medical School. So we begin to think that whether ketones could supplant glucose as a major source of energy in these tumor-initiating cells. And in the top left curve, you can see here that in the absence of glucose, the cells plateau, they stop growing. But now when you, in the absence of glucose and you supplement with ketones, you can see that the cells now continue to grow and they are tumorigenic when you put it into the animals. And what happens if you give these animals ketogenic diet? In fact, contrary to what we know about ketogenic diet that is good for health, in a cancer patient, actually, ketogenic diet could potentially have an adverse effect, especially as shown in the mouse models. You can see here that in the normal diet, the tumors continue to grow in the black line shown there, whereas in the ketogenic diet models, you can see that there's actually this increase or an increased growth of these tumor cells. And not only are these tumors bigger, but they are also more invasive and contain more cancer stem-like cells, which are more resistant to treatment. So ketogenic diet, in fact, in these animal model studies, promotes the growth of the more aggressive tumor cells shown here. How can we exploit the reliance of these tumor-initiating cells on ketogenic diet as a form of therapy? So as it turns out that these tumor-initiating cells actually import ketones through this transporter called MCT1, which they bring into the cells. So in the absence of glucose, they are highly addicted to this use of ketone bodies for their survival. So we make use of this addiction by giving the mouse ketogenic diet. And you can see that if we use a transporter inhibitor called MCT1 transporter inhibitor, that it reduces the growth of the tumors. But if we now combine it with a ketogenic diet, now we ablate the tumors even further. And this is a concept that we call metabolic addiction with this in these tumors. So we can now prime the tumor cells to become addicted to a certain form of nutrient through dietary intervention, and in doing so causing addiction to the pathway, and then hit it with the inhibitor that targets that pathway. So what I give you are some examples of dietary intervention in cancers, and there are many examples right now that has been published as well. So this is really the concept of precision nutrition, not just talking about Mediterranean diet, or fasting or ketogenic diet, but very precise nutritional manipulation such as methionine depletion, cysteine restriction, serine reduction, folate supplementation or folate depletion could be combined with different forms of pathway inhibitors to enhance this therapy response in these cancer patients. And in fact, this is not just a postulation. There are now many trials that has been used combining diets with various forms of precise therapy or chemotherapy or targeted therapy. The results will be coming out, I think, in the next few years on whether diets will work in synergizing with therapy response as well. And finally, to end off with this slide, which that although dietary intervention can be a novel means to treating cancer or improving the response, there are various challenges associated with that. Some examples I have listed here you can read on your own, such as the metabolic heterogeneity, which I mentioned, different cells using different metabolic pathways. How do you target all at the same time? Metabolic plasticity, they can actually switch between using different pathways when nutrients are absent. Host versus tumor effect. Whatever metabolic interventions that you use for your tumor cells would also affect your whole cells, so you need to consider the toxicity associated with that. And then patient-related issues such as malnutrition and cachexia, treatment-drug interactions, and finally, perhaps one of the more difficult ones is trial design as well. How do you make sure that the patients adhere to this dietary intervention and make sure that the results collected is accurate and reflective of that, such as you need to have good tissue access, you need to have a mechanistic readout to know that this is the effect of the diet. With that, thanks very much.
Thank you so much, Dr. Tam. I'm not sure how we're going to keep Char Kway Teow away from a Penangite like myself. Next, I will invite it's my humble pleasure to invite Dr. Kylie Loh to come and speak to us. Really, he's very well known to us. He's working as a medical oncologist in Penang Adventist Hospital. He got his training from Melbourne, including Peter MacCallum Cancer Center. And we were talking about pickleball yesterday, Dr. Kylie. And now you're going to talk to us about exercise in cancer care.
Yes, thank you, Nina. So I promise you my talk, you can pronounce the words. You will understand every word I say, okay? All right, so thank you. So thanks for giving me the chance to talk about exercise, something I'm passionate about. Okay, so how will exercise help my cancer treatment? It can be for you, it can be for the patient as well. Okay, now these are my disclosures. So I'm no scientist, so I see patients like most of you in clinic. Okay, so if you imagine if you have a patient like this, a 47-year-old lady with clinical T2N1 triple-negative breast cancer that you're preparing for neoadjuvant therapy. And beyond the chemos and all the drugs and all that, most likely she will ask you, is there anything else I can do to improve my outcomes? So being in Asia, supplements, okay, this herb, that vitamin, and alkaline water, and so forth. Okay, so I'm sure all of you have come across that. Then there's this cancer-fighting foods. Don't take this, don't take that. Okay, so no fructose corn syrup. Okay, so but in my years as a clinician, I would dare say that no one actually asked me about exercise. Okay, doctor, should I exercise? It's more of like, oh, should I rest more? Okay, now, so I think it's important to understand first what is and what isn't exercise. So exercise is defined as physical activity that is planned, structured, and repetitive. So aiming to improve or maintain fitness. Okay, and that's like running, like pickleball, like going to the gym as well, like doing weights, walking your dog, okay, or doing house chores is not exercise. Okay, because when you say exercise, most of the women will say, oh, but I vacuum the floor, I fold the clothes, I hang the clothes, so yeah. But that's not exercise. That is physical activity. Okay, which is any movement produced by skeletal muscles requiring energy. So very different, yeah? That's not exercise. And then on the other hand is rehabilitation. So this is also different from exercise. This is a physical intervention to restore function, reduce impairment, and enabling ADLs. So these are people who are already disabled. And then there's also not exercise. So this talk is going to focus on exercise. All right. So what's the hype about exercise? So there is reasonably good data to suggest that it does reduce the risk of getting cancer. It also improves survival in cancer patients. It reduces side effects from our treatments, and it also improves quality of life. Now, so in terms of reduction in cancer risk, there's reasonably good observational data, okay? And especially in breast cancer, since this is APBCS, pretty strong grade of evidence, about 12 to 21% reduction in cancer risk, and there appears to be a dose response. Okay, so the more you exercise, the higher the benefit. Okay, and how about the risk of recurrence of exercise? So based on observational data again, okay, there appears to be 21 to 24% reduction in breast cancer recurrence. Okay, there is no prospective level 1 evidence as yet. How about survival? Again, based on observational data. So for breast cancer, there is a reduction in all-cause mortality as well as cancer-specific mortality. Now, so if we drill down to the data itself, okay, it appears that even some level of exercise, so MVPA stands for moderate to vigorous physical activity, okay? So at baseline, it's associated with better survival. So even if you exercise 1 to 2 days a week compared to 7 days a week. Now in terms of, so this shows us that there is still an impact of exercise even if your patients were previously inactive. And then after they've seen you, you've given your exercise rundown, and they agree to follow you, they will still benefit. Okay, so this is really important for patients. So it's not like, oh, I haven't exercised in the past, I have got cancer now, that's it for me. No, they will still benefit. So again, these are retrospective observational studies. Now, so where's the prospective evidence in all of this? So this is actually the challenge trial. So some of you who do other cancers as well, so this is actually a randomized phase 3 prospective trial of exercise. Okay, so in this case, supervised exercise with behavioral support, okay, over 3 years versus general health education materials, i.e. nothing, okay? So, and the primary endpoint is disease-free survival. So it's what's so nice to see after, over 10 years since the trial was started. So this was published in the New England Journal of Medicine on the 1st of June last year. So structured exercise after adjuvant chemotherapy for colon cancer. And it met the primary endpoint. So it showed an improved disease-free survival, okay, compared to education, i.e. nothing. So a 28% reduction in a disease, in an event. And when we look at overall survival, there was also an improvement in overall survival with a hazard ratio of 0.63, so that would be a 37% reduction in risk of death with exercise. Now, so this is the first prospective RCT, okay, showing that exercise actually improves DFS as well as OS, but unfortunately in colon cancer. This is APBCS, right? But still, it's still a milestone in the whole field of exercise oncology. Now, if you look at exercise, DFS and OS, there's a 5 to 7% DFS benefit, hazard ratio of 0.72, but absolute benefit of 7% in overall survival, hazard ratio of 0.63. If you compare that to 5FU, okay, well, hazard ratio of 0.7 to 0.75 in DFS and 0.75 for OS. And what about oxaliplatin? appears to be the same, right? So this brings about the question is, wow, exercise could actually be as good as the chemotherapy that we give in colon cancer, okay? So what about breast cancer? So this is the OptiTrain trial. So the primary endpoint is actually cancer-related fatigue. So this is in breast cancer patients, a reasonably large trial, 240 patients, large for exercise oncology standards. So they were randomized to 3 arms. So the first arm is resistance training, which is basically doing weights, okay, in combination with high-intensity interval training. Okay, so that's quite difficult. Patients were also on moderate to vigorous intensity aerobic exercise and HIIT versus usual care, which is nothing much, okay? So, what did it show? So they showed that exercise reduced cancer-related fatigue. So they met the primary endpoint and symptom burden during chemotherapy. It also reduced body mass, which is expected, improves quality of life and emotional functioning, and as well as associated with a higher return to work rate. But the benefits were sustained to 2 years, but not 5 years. Okay, so this trial only had exercise for about 16 weeks. Okay, which is different compared to the challenge trial in colon cancer. So they had supervised training and behavioral coaching for up to 3 years. Okay, so exercise or the intervention that we use, it has to be sustained. Now, in terms of cancer-specific outcomes, so patients who exercise had better invasive breast cancer-free survival. Okay, and they combined their data with other similar trials in breast cancer as well, and they showed, if you pull the data together, there was, so in terms of overall survival, hazard ratio of 0.55. So that's like a 45% reduction in death, right? And in terms of recurrences, hazard ratio of 0.67. So that's like a 33% reduction in recurrence. So it is highly suggestive, okay? Now, in terms of us answering the question, why does exercise work or potentially work? So this is the LEANER study, which is a randomized trial of exercise and nutrition on chemotherapy completion and pathologic complete response in women with breast cancer. So this trial had stage 1 to 3 breast cancer patients who were having chemotherapy and were already at below physical activity and nutrition guidelines, like most people in Penang. Right? So 173 patients, okay, all right, so they were randomized to nutrition and exercise for 1 year, okay, versus usual care. So nutrition counseling was pretty simple, okay, more plant-based, less sugar, less red meat, less processed food, less alcohol, more fiber, stuff that we all generally tell our patients already, okay? And exercise is standard guidelines exercise, 150 minutes or more of moderate intensity or more than 75 minutes of high intensity physical activity, plus twice weekly strength training. Okay, so they didn't meet their primary endpoint, which was to show improvement in chemotherapy completion rates, so it was similar. But their secondary endpoint, they showed an improved PCR in the hormone receptor positive and triple negative breast cancer cohort. Now, this is the PREHAP study from the US by Jennifer Lickebell. Okay, so this is interesting. So it showed, so it's about the impact of preoperative exercise on breast cancer proliferative and gene expression. So they basically biopsy the patient, sequence the tumors, exercise them for 2 weeks, and then go for surgery, and then sequence the tumors again. So it's the first study to show a direct impact of exercise on breast cancer itself. So there were no changes in proliferation biomarkers, but there was significant upregulation of 18 unique molecular pathways between the diagnostic biopsy and the surgical biopsy, which is centered around immunity and inflammation. So there is emerging sort of scientific or preclinical data to suggest the anti-cancer effects of exercise, which I won't bore you with. Now, in terms of side effects, which is what it is mainly known for, so exercise has shown a reduction with issues with anxiety, depression, less fatigue, better quality of life, and so forth. So it is shown to be effective at reducing side effects. So this is a really nice trial called the HOPE trial. Okay, so it's a randomized exercise trial of AI arthralgia in breast cancer survivors. So AI MSK problems is very common for us clinicians here. Okay, and so they randomize patients with stage 1 to 3 breast cancer who have had 6 months or more of AI and have significant joint pain. So they randomized to exercise for 1 year, and that is the standard exercise guidelines, 150 minutes or more of moderate intensity, plus twice weekly strength training versus usual care. So they showed those patients who exercise actually had less AI-induced arthralgia. So this is something that I would recommend my patients for those who have significant symptoms. So in terms of guidelines, so this is the ASCO guideline, the summary of which is this. So it says that oncology providers should recommend aerobic and resistance exercise during active treatment with curative intent to mitigate side effects of cancer treatment. Okay? Now, so this is Prue Cormie, so at TEDx Perth. So she's an exercise researcher. So this is what she said. So if exercise, or if the effects of exercise could be encapsulated in a pill, it would be prescribed to every cancer patient worldwide and viewed as a major breakthrough in cancer treatment. But Prue, exercise is not a pill, okay? Now, so exercise is actually a behavioral intervention. So it's not as easy as popping a pill into your mouth. Now, but still there are some similarities. So in terms of exercise, we also think about the dose. We need to also prescribe the exercise, and we use the FIT protocol. So what's the frequency of exercise? What's the intensity? How much time? And what type of exercise? And we need to also focus on the adherence to exercise, right? So supervised sessions have consistently been shown to have better outcomes compared to just reading material, okay? And coaching is also quite important. So if you look at the challenge trial, they had both of these. So patients had access to coaching for the 3 years. And how do we deliver exercise to really have the best outcomes for patients? We really need formal or specialized programs. And this is more like a system-wide approach on how we're going to deliver exercise to our patients. And of course, qualified exercise professionals. So exercise is good, but it's not easy, okay? So this is my patient with her consent, and that is the trainer that I use here in Penang, and he's also my trainer as well. And we have to remember it's a behavioral intervention. If you're seriously going to recommend exercise to your patients, I bug them almost every single visit. Are you exercising? What have you been doing? Okay? And exercise and access to exercise programming and qualified professionals is really key. Okay? So this is my 78-year-old triple-negative stage 3 patient on neoadjuvant Keynote 522. If she can do it, you all can, okay? So, okay, she can pull you on the floor, okay? So, okay, but even if your patients can't do this, anything is better than nothing, okay? So coming back to this patient, I would recommend exercise to her because it reduces treatment side effects, it may reduce recurrence, it may improve survival, and improves quality of life. Thank you very much.
Thanks very much to all speakers. Just checking if we have time. 5 minutes, okay. 5 minutes for Q&A. So 10 minutes, okay. All right, may I invite all the speakers back on stage? And in the interest of time, I'll start off with 2 questions and I'll try and group them together. So maybe since we just talked about exercise, Kylie, both to Kylie and Eric, for all the audience today, what would be key activities that you would recommend from the implementation perspective to really make this work for patients and get it reimbursed? And to Tira and Wai Leong, you have a bit more time to think, but if you were to design a precision nutrition trial, maybe an adaptive one, this treatment with this, avoid this, what would that look like? So maybe to Kylie and Eric first.
As in, how do you get it to the masses, is it?
Right. So for what you do for your patient, if everyone else wanted to do that, what were key things to implement to make it work? And if you want to get it reimbursed?
I will leave the reimbursement to Eric. Okay, so in terms of making it work, it starts with all of you. Okay, so so you need to actually, because it's a behavioral intervention, so you need to talk about it all the time. Okay, I often reference myself exercising as well, and sometimes I see them at the same gym as well, so that helps to see that their own doctor is exercising. You really need a qualified exercise professional, because exercise does also come with some risks as well. They can get injured, so you need a qualified exercise professional. But that's what I do in my little clinic, and it seems to work. But how do we get it to broader groups of patients? It's a challenge here.
Let me talk just quickly about reimbursement. I mean, generally, payers are schizophrenic, right? And so they'll tell you they want 3 things. And, the reality is every payer wants to spend less. That's public and private payers alike. But they will also tell you they want a value for money. So they want high-value treatments. They want to maximize outcomes per dollar spent. And then they will also tell you they want game-changing technology that can really improve the lives of patients. But the reality is game-changing technology comes with patents, comes with high prices, and it raises expenditures. And so, my general feeling is that governments and private payers have fixed budgets, and I think focusing on value for money is critical. You have to show safety and efficacy, of course, but I think a value proposition is going to show that you're cost-effective based on established thresholds for cost-effectiveness, and increasingly that you're not going to break the bank. And so there's some budget impact assessment that's affordable. And I think increasingly there'll be push for outcome-based pricing so that governments don't have to pay for interventions that just don't deliver. And I think the industry needs to start to become more receptive to those types of strategies. So I'll stop there. Quick answer.
Thanks, Eric. And maybe before Tira and Wai Leong, we have a question from the mic.
So questions for Wai Leong. That was fascinating, although very scary, to remind us of the evenings that we spent before biochemistry exams, cramming in the Krebs cycle, etc., to try and to pass the exam. Now we actually realize it's got some utility. You mentioned during your talk that there was a relative upregulation of some of those biochemical metabolic pathways compared to us normal folk. So we're used to sort of, a mutation and you have a drug that blocks it, or you have overexpression of a protein and an antibody binds to it. So can you give us a little bit more about how you would have that differential effect in abnormal metabolism, like in your immune system or in your cancer cells, and how we would target it?
Thanks for the question, right? So I think one of the key challenges for targeting the metabolic pathways or metabolic inhibitors is actually the overlap of pathways between normal cells and tumor cells that they use. So any metabolic perturbations that affect the tumor cells likely will also affect some tissues in the normal cells as well. So I think one thing is the therapeutic window that we look at. The other one is combination with different forms of therapies to enhance that of the dietary intervention as well. I don't think that diet should be used alone as a form of therapy for sure. Any extreme diets will probably have detrimental effects, I feel, for the patients as well. And going back to the question that was asked earlier, understanding in terms of designing a trial, the mechanistic link will be important in choosing how to pair dietary intervention with a specific form of therapy. We need to understand that. The second thing that I did not mention is actually the biomarker selection. We need to have a biomarker to select for patients that will actually respond to that form of therapy. Just as an example, in the lung cancer study that we are performing, we think about how to design a trial. We probably want patients with high expression of this receptor called CD147 or CD166 that is associated with the high transport of ketones into these tumors. We don't want to take any tumors to do that because otherwise you will select for a resistant population that can adapt and to adjust as well.
We do have a question from the floor, yeah?
Hi, I've really enjoyed this conversation and this session. So I have two questions. The first question is, when we're talking about hope for patients, would you be able to comment about the hope that patients' relatives also put within the equation when we actually see our patients? Because I think that, especially in this part of the world, there's a lot of that driving as well, the hope that comes from the relatives. So that's the first question. And then the second question I will ask later.
You're absolutely right. And in fact, a lot of times what we see, and I'm sure what you guys as clinicians see, is that it's the family that is pushing aggressive treatment even beyond when the patients are saying that's enough. And I think part of it is driven by hope, but part of it is driven by regret and fear and other factors. And I think the question that we really have to think about is how do we get patients, and by the way, clinicians also have hope. I mean, certainly they want to see great outcomes as well, and they sometimes, I would argue, are probably biased in their judgment as well. How do we get patients to make decisions or families to make decisions that we think are unbiased? And I think we owe it to taxpayers who are subsidizing these treatments to make sure that we're not spending money on things that are low-value treatments. And I'm a big believer in medical decision aids that can help patients make better choices, but I also think no doubt hope induces overtreatment, but we have to be careful because the last thing we want to do is take these patients at a critical time and say, you're a goner, you're not going to... So we have to recognize the trade-offs between some levels of hope and maintaining hope and overtreatment, and that goes for the patient and the families as well. But I think we can't just assume that what we're telling patients and what we're telling the families, that they are internalizing and then making decisions based on that, because the evidence just doesn't support it.
Thank you. And then my second question is really to the panel. It's very interesting because I see that, exercise and diet play such a big part in our patients and also in probably a lot of the cancers that we see that are developing. So it's a little bit like, has the horse bolted and we're closing the stable door, or should we actually be intervening at a younger stage or an earlier stage with our children or the younger people in trying to get them educated in terms of the importance of regular exercise and diet and making correct choices?
I think that's happening now because kids are not going out anymore to party and to drink. They're going to the gym and hanging out with their friends in the gym. There's a real gym-going community now. So I think that's switched, and I think there's been a lot of sort of public education, and people are just more they're more health literate, so they're more aware of what is healthy and what is not. So I personally am seeing a little bit of a shift already, and it's definitely good that we start early. The habits builds and forms early, and it can carry on through. And then hopefully we won't be treating cancer anymore, rather we're preventing it, right? That's what we want to strive towards.
Thank you.